That's a great question. So one of my roles is educating primary care staff in motivational interviewing. And I think one of the biggest barriers to motivational interviewing is time. Time is money in healthcare. And so one thing that's really important to recognize about motivational interviewing is not only is it patient-centered and collaborative and allows us to elicit their own reasons for change, it also can be done efficiently. So research tells us that motivational interviewing can be effective in either 15 minutes or even one session, depending on the research you're looking at. And so I think it's useful for providers to know that they can use motivational interviewing efficiently. I think it's also important to recognize that in the context of an opioid taper conversation or when you're talking about someone's pain management in general, I think that providers often feel like they're put in a position where they have to be in confrontation with their patients. What motivational interviewing gives us is a way to join with our patients without feeling like we have a push-pull with them, that we're fighting with them. It allows us to elicit their own reasons for change rather than trying to impose our own reasons for change. And we often will see that a patient may be more likely to commit to a treatment plan or be engaged in a treatment plan because it fits with their own values. That's a good question, and I think it's something that is increasingly being taught, but if you were to ask, for example, pain medicine practitioners here at this conference or people in practice, oftentimes you might hear, I never got any of this in medical school. Where I trained in San Francisco, a lot of the residents were receiving motivational interviewing training, and I think it's starting to make its way into medical training, but we certainly need to see more. I think big picture, one of the biggest challenges is that we've been in a culture and a paradigm with pain medicine that a quick fix is going to be the most effective for pain management. It's something that's embedded into our culture, and it's something that is aligned with the medical model of care, that our providers generally don't have a lot of time with patients, and because they're helpers, they want to be able to have the patient walk out the door with something. And I think one of the most important things is to recognize that even though it takes a lot of work up front and it takes maybe a shift in how patients perceive their care and their relationship with their pain management, is they need to do a lot of active strategies for pain as well. So passive strategies like medications or injections, those all help support a patient's engagement in, say, a physical therapy program or aquatherapy or a walking program. And so the paradigm shift really is in thinking about how it's important to think about chronic pain like a chronic disease. And the example we often use is like diabetes. So if you have diabetes, maybe you have to check your insulin every day. You have to take a medication. Maybe you have to engage in exercise and stress management. Living with chronic pain is often like living with a chronic disease in that manner. There's something you have to do every day, and it's probably a mix of different strategies.